We are live, please.
Yeah, welcome everyone, and we welcome yet another Journal Club meeting of season 5. We are into the 5th season, and this is all thanks to the presidents and the secretary, MOS and BOA, who have supported us for this Journal Club meeting. So today we have a very interesting topic of cataract surgery in extremely small eyes. So this everything happens on the journal club meeting is because of a small team, and I would like to take a minute just to tell about the team. That this team consists of Dr. Parul Deshpande, Dr. Zain Khatib, Dr. Neeraj Israni, and Dr. Sabyasachi Sen Gupta, who are the brain behind doing this journal club meeting. And because of them, their support, the teamwork, this is happening. So I would first ask the MOS President, Dr. Anaga Hirur, to open the meeting and say 2 words. Dr.
Yeah.
Anaga, please.
Yes. Good evening, one and all, and welcome to this one more session of the MOS and BOA Journal Club. And it's really heartening to see how we take interest and focus on these specialty topics so that we delve deep into the focus on these subjects and then have insights of various expert panelists also. So thank you everyone for your valuable time, and I think let's dive in straight into the topic. Yeah.
Fine.
Thank you.
And this season, we are welcoming the President BOA, and this is his first official meeting of the year. So Dr. Omkar Telang has been very dynamic, and he will we open this tenure with this meeting. So Dr. Omkar, please
Thank
say
you,
a 2 words.
Thank you, Vaishal, for your kind words. Being a teacher, I like to be a part of the journal club. I think you, along with Neeraj, Zain, Parul, have taken the journal club to another level with support from MOS as well as from NTOD. So let's begin the journal club season 5. Thank you.
Thank you. So we have a galaxy of stars today uh, as faculties today, and I would ask Dr. Zain Khatib to introduce them.
Thank you, sir. So, for this topic, which is cataract surgery in hyperopic eyes, we have, very esteemed national and state faculty. In the national faculty, we have with us Dr. Matthew Kurian, sir, who is the head of Chaitanya Eye Hospital and Research Center. He's a very high volume cataract and refractive surgeon with more than 50,000 surgeries performed over a 20-year career. His expertise includes advanced intraocular lens implantation and correction of high refractive errors, including phakic lenses. So, welcome, Matthew, sir. Next, our national faculty, we have none other than Dr. Krishna Prasad, sir, who has been a personal teacher to me during my residency days. He's the head of pediatric ophthalm and glaucoma services at Joshi Eye Institute, and he is renowned all over India for his dedication towards teaching ophthalmology education, along with that even community services, and he has a special focus on glaucoma pediatric eye care, and he has a rich academic background with numerous accolades. Dr. Krishna Prasad significantly contributes to both clinical practice and training of future ophthalmologists. Welcome, KP sir. Thank you so much for removing time. And then we have our very own state faculty, Dr. C.M. Vavikar sir, who again, is a mentor, personal mentor to me. He's the head of Vavikar Eye Institute in Thane and in Navi Mumbai. And Vavikar sir is a legendary name in ophthalmology and cataract refractive surgery. He has done training specifically in refractive surgery from Italy, Germany, Singapore, and Australia, and one of the first pioneers of to perform true bladeless cataract surgery in India. So, welcome, Vavikar sir. So, thank you all our esteemed panelists for agreeing to be part of this journal club meeting. Dr. Neeraj, over to you to introduce our speaker and moderator.
Thank you, Dr. Zain. So we have our very esteemed moderator, Dr. Naina Poddar, who has specially joined us in spite of traveling. Dr. Naina Poddar is a professor and head of department, Nair Hospital, Mumbai. She has a 30-year experience, and she's experienced in pediatric ophthalmology, community ophthalmology, and she has been a teacher and guide to more than to hundreds of postgraduate students for more than 25 years and is also a DNB examiner. Not only this, but she has more than 50 index journal publications and many awards and papers to her name. Apart from that, we also have another speaker, another moderator. Just give me 1 second. So, the second moderator of our session is just 1 second.
Dr. Anuja.
Yes, just I have it written with me. Yeah, Dr. Anuja Gharat. Dr. Anuja Gharat is the professor and the head of department of ophthalmology again, Nair Hospital. She has an experience of more than 13 years in UG training as well as PG training, and is also in charge of various other extracurriculars such as mobile ophthalmic van and community ophthalmology in Nair Hospital. So I welcome both of them. I would also like to introduce Dr. Chaiti, who is a senior resident from Nair Hospital, final year resident, and she will be presenting the entire paper today. So I think without much ado, I would now hand over the dais to Dr. Chaiti Aranke, who would now present the topic, after which we will be carrying forward the entire session. Dr. Chaiti, are you there now? Can you present? Can you share your screen?
Yes, sir. Yes, sir. Am I audible?
Yes.
Yes, sir. Thank you so much. I'll just share my screen.
You will have to press this share button, the green color share button, and then
Yes, sir.
you've already done it yesterday.
Yes, sir. I have done it yesterday. But is the screen seen now?
No, Sunilji, can you just
No, doctor.
Sunilji, I have sent you the presentation also. If you want, Chetty, I can, if we don't have to waste much time, I can play the presentation from my side if you want to present.
Yes, sir.
No, what
I'll
is the
just try it
problem?
once.
Yeah, just share your entire screen.
Yes, sir. Yes, sir. So I'm sharing the screen, but
Okay, no problem. Or Dr. Neeraj, you can play it.
Yeah, I will just play the presentation and she can present it from there. No problem.
is it seen now by any chance?
Yeah.
Yeah,
It's
your
seen.
mobile screen is seen now. You can present on this. Yeah.
Okay. Yes. Yes. Please hold on for a minute. I'll just put it on. I'm sorry for this technical error.
You are on your phone right now?
I'm on my tablet, sir. My laptop phone.
Okay, so can you rotate it? Yeah.
Yeah, perfect.
Yeah. Is it fine now?
Yes.
Absolutely.
Okay. And I hope I'm audible too.
Yes, go ahead.
Yes, sir. Okay. So good evening to the esteemed panelists, the faculty members. Sorry.
No, continue, Dr. Chaiti.
Okay. Yes. Okay. All right. A very good evening to the esteemed faculty members, the esteemed panelists, and one and all. I, Dr. Chaiti Aranke, a senior resident from the Department of Ophthalmology, Nair Hospital, Mumbai, would like to thank the MOS and BOA Journal Club team, Dr. Naina Poddar, ma'am, HOD, Department of Ophthalmology, Nair Hospital, and Dr. Anuja Mihir Gharat, ma'am, Professor, Department of Ophthalmology, Nair Hospital, and a moderator for the current session for providing me this opportunity and helping me out with the current article titled Cataract Surgery in the Extremely Small Eye, Morphology, Comorbidities, and Outcomes in 300 Eyes by Maximilian Hammer, Lily Tite, Maximilian Friedrich et al., which featured in the British Journal of Ophthalmology, the 2025 issue. The purpose of this study was to define the morphology of cases receiving high-power IOLs from a real-world data set of tertiary care ophthalmology department with a specialization on complex lens surgery. and to delineate a better preoperative management of patients' expectation through the findings of a big cohort included in the study. The prevalence of high hyperopia and an extremely short axial length in the general population is around 1 to 2%. Compared with high myopia, morphological data and outcomes for this patient population undergoing cataract surgery are sparse. Based on their axial length, anterior chamber depth, corneal diameter, and refraction, extremely short eye is often presenting with a high hyperopic refraction can be categorized into posterior microphthalmos, relative anterior microphthalmos, and nanophthalmos. These eyes may require high power intraocular lenses, that is, with a power of 30 diopter or more, for capsular bag implantation or treatment with a polypseudophakic approach. These IOLs hold inherent downsides like a higher manufacturing tolerance, limited availability, and an increased inaccuracy in the effective lens position and thus in biometry. Combined with a shallow anterior chamber, outcomes of cataract surgery in this patient collective have been reported to be worse and less predictable than in an emetropic cohort. Previous studies have either not differentiated between the above mentioned morphologies, included only a small number of eyes, or have exclusively focused on certain aspects of cataract surgery, such as IOL calculation. Coming to methods, this study analyzed cases undergoing cataract surgery at the University Eye Clinic Heidelberg between January 2009 and December 2023 using de-identified data from a database of 25,586. Adult patients undergoing surgeries with implantation of a high power IOL of 30 diopter or more were included. Cases with implanted IOL power of less than 30 diopter, those with missing biometry data, and those with aphakic or pseudophakic lens status, as in IOL subluxations or revision surgeries, were excluded. For all patients, HIGIS, SRKT, and Holiday 2 were calculated. Modern formulae were not available at the time of surgery for most of the cases. Surgeries were performed by one of 5 experienced surgeons. Patients underwent lens surgery using clear corneal incision, aspiration of the crystalline lens using the phacotip, bimanual aspiration and irrigation, followed by implantation of IOL in the capsular bag. In case of toric IOLs, the lens was aligned using manual markers or with the assistance of Varion system or Callisto system. Patients underwent intraocular pressure measurement using Goldman applanation tonometry on postoperative day 1. Data pertaining to preoperative morphological features was obtained using IOL Master 700 and 500. Corneal topography and the anterior chamber angle details were retrieved through Scheimpflug tomography. OCT data and analysis through HAYEX platform. OCTs were performed post-operatively only when cystoid macular edema was suspected. Eyes were categorized into 4 groups based on their morphology. Those with preoperative refraction more than 5 diopter, axial length more than 20 mm, anterior chamber depth more than 2.2 mm, and with a corneal diameter of more than 11 mm were classified under high hyperopia. Those with axial length less than 20 mm were classified under nanophthalmos. Those with anterior chamber depth less than 2.2 mm or corneal diameter less than 11 mm, but with the axial length more than 20 mm were classified under relative anterior microphthalmos. And those of the majority of the eyes which did not fall into the other 3 categories were categorized as moderate hyperopia. Visual acuity values were translated from decimal to logmar, and only values 7 days or more after the surgery or farthest from the surgery were considered. Effects on visual acuity were also assessed in a patient cohort with available postoperative data on best corrected visual acuity 1 month or more after surgery. Eyes with diagnosed amblyopia were excluded and primary analysis were reconducted. Stata V.17BE software was used for statistical analysis. So from a database of 25,586, after applying the exclusion criteria, 300 eyes of 191 patients were included as in the primary cohort. Coming to the morphological data, 136 eyes were classified under high hyperopes, 68 under nanophthalmos, 58 under moderate hyperopes, and 38 under relative anterior microphthalmos. The axial length was average was found to be 20.68 plus minus 0.92 millimeter. The corneal diameter 11.9 plus minus 0.49 millimeter. The anterior chamber depth 2.59 plus minus 0.39 millimeter, and the corneal power was averaged at 43.6 diopter, which was close to the emetropic population. Surgical intervention significantly increased the chamber angle in all the quadrants. Preoperative ocular morbidities, which were associated with these extremely small eyes, were amblyopia, previous strabismus surgery, and glaucoma. 44 eyes were found to be amblyopic. 22 out of 300 of the study eyes had undergone previous strabismus surgery prior to cataract surgery, and glaucoma was prevalent in 12.7% of the study population. Nearly a quarter of all non-ophthalmic eyes had glaucoma. Non-ophthalmos and relative anterior macrophthalmos had the highest preoperative iridotomy rates, which were 13.2% and 26.3% respectively. This is further reflected in the indication for surgery, as cataract surgery was performed as an anti-glaucomatous measure in 10% of the cases. These were some of the rarer comorbidities associated, like previous filtrating glaucoma surgery, anti-neovascular intravitreal therapy, previous lid surgeries, previous corneal surgery, previous syneculitis, and previous vitrectomy. Axial length moderately correlated with the IL power. In the non-ophthalmic eyes, IL power was significantly higher with an average of 34 diopter. We can in the below graph we can also see two outliers between 50 and 60 diopter. 49 of the cases were implanted with a toric IOL, and 18 of the 300 eyes received multifocal IOLs. Mean preoperative spherical equivalent was found to be +6 ±2.85 diopter. As we can see in the first histogram, most of the population was found to be highly hyperopic, with one hyperop also found to be +17 diopter on the extreme end. 288 eyes were targeted at emetropia with post-operative spherical equivalent of -0.42 ±1.56 diopter. From all eyes with emetropic target refraction and available post-operative refraction, that is considering all considering the loss to follow-ups, 127 eyes were studied, and 68.5% of them were within ±1 diopter of their target refraction. 85.8% landed within a 2 diopter range, which is evident in the second histogram. 11 eyes were targeted for a refraction of -1 to -2.5 diopter, and one eye aimed at +4 diopter to fit the partner eye. There was no statistically significant difference between the preoperative corrected distance visual acuity and the postoperative uncorrected distance visual acuity. Whereas there was a slight but a statistically significant improvement between the preoperative corrected distance visual acuity and the postoperative corrected distance visual acuity, which is visible in the first graph. Postoperative uncorrected distance visual acuity was significantly greater in highly hyperopic eyes compared with non-ophthalmic eyes. No statistically significant difference in postoperative corrected distance visual acuity was apparent between the three morphologies. In 3% of cases, a posterior capsule rupture with vitreous body prolapse requiring anterior vitrectomy occurred. 2 cases showed an elevated intraocular pressure on postoperative day 1, which could be controlled with topical therapy. On average, intraocular pressure was significantly lower on postoperative day 1 with a mean pressure reduction of 2.2 mm mercury. 16 of the 300 eyes showed a newly developed cystoid macular edema postoperatively. After excluding eyes with known amblyopia, postoperative uncorrected distance visual acuity was still not significantly different to preoperative corrected distance visual acuity. 1.2% was found to be the prevalence of extremely short eyes, that is 313 eyes out of a database of 25,586 eyes, which was high. Amblyopia rate in the cohort was extremely high with a rate of around 15%, as most of the preventive measures were discovered in the past 1 decade, and mean axial length of the cohort studied here is drastically lower. The average axial length in the angle closure glaucoma group was 12.92 mm reported in George et al., while this cohort showed an axial length of 20.68 mm average. Non-ophthalmic eyes and eyes with relative anterior microphthalmos showed higher rates of glaucoma than highly hyperopic eyes, and also higher rates of young iridotomies to relieve angle closure. The study reported a prevalence of around 18.5% in relative anterior microphthalmos and even higher prevalence in nanophthalmos eyes of over 20%. No clinically relevant difference in the visual outcomes between the morphologies was found. Preoperative visual acuity strongly predicted the postoperative success. Preoperative refraction was significantly different between the three entities, with nanophthalmic eyes reaching the highest average refractive error of over 7 diopter. Multiple studies confirmed that Hygie's was more precise in small eyes. In another article by Kane and Mellis, the Kane formula and the emetropia verifying optical 2.0 slightly outperformed the Hygie's formula. Coming to limitations as expressed in the study, retrospective nature of the data may limit a more detailed analysis, in particular of the early postoperative corneal edema, pachymetry, and inflammation status. Also, the German healthcare structure incentivizes a quick handover from surgeons to conservative ophthalmologists, creating a larger percentage of loss to follow. The study comprises the largest cohort to date of eyes with implanted high-power IOLs. Lens surgery is safe in these eyes. However, high prevalence of comorbidities like glaucoma should be kept in mind. Pronounced visual gains are uncommon in this population. However, uncorrected vision improves and surgery provides spectacle independence, leading to good patient satisfaction. Coming to Mary effect, study question, population, and period were well defined in this retrospective cohort study, and the assignment and assessment were appropriate. The results defined morphological data as the average axial length was 20.68 plus minus 0.92 millimeter. Corneal power averaged at 43.6 diopter. The preoperative ocular comorbidities were found to be amblyopia, glaucoma, and previous strabismus surgery in the said order. Preoperative spherical equivalent was plus 6 plus minus 2.85 diopter. The postoperative spherical equivalent was minus 0.42 plus minus 1.6 diopter. Preoperative corrected distance visual acuity and postoperative uncorrected distance visual acuity were not significantly different, and the postoperative corrected distance visual acuity was slightly improved. The upsides of the study were that it was a large cohort with a systematic morphological assortment. It provided a valuable insight into comorbidities which can occur in extremely small eyes. Also, the study population was optimally corrected when it comes to refraction. So it was logical to say that the postoperative uncorrected distance visual acuity could be predicted to be somewhere close to the preoperative corrected distance visual acuity. And this can provide us a valuable guideline for preoperative counseling in such patients, especially or only in the cases when they have early cataractus changes, which can be optimally corrected when it comes to refraction. Coming to it would have been better if the study had provided a clarification on ultrasound biomicroscopy and custom-made IOLs, as this modality is often used for sulcus to sulcus measurements, which is necessary in custom-made IOLs. Fundus findings could have been present in this study for sure, considering a huge cohort and also considering the morphologies like nanophthalmos and posterior microphthalmos. As in cases of Edelman type 1 and 2 fundal colobomas, optical biometry in such eyes would not be accurate due to altered fixation, which would interfere with the visual outcome, besides the pathology affecting the visual outcome itself. 49 patients were implanted toric IOLs. However, preoperative degrees of astigmatism and postoperative residual cylinder have not been mentioned in the study. 9 cases had the complication of posterior capsular rupture. It would have been interesting to know if this PCR had some correlation with a particular morphology, considering the fact that we are studying about morphologies. Sclerostomies are surgical maneuvers which are performed in nanophthalmos and at times in posterior or at times in posterior macrophthalmos, where uveal effusion can happen to occur intraoperatively. It can also occur spontaneously, but a mention of the same has not been done in the study. Coming to this graph on postoperative corrected distance visual acuity, the box and whisker chart of the plot of the moderate hyperopes would be expected to be more condensed as compared to the other three morphologies. In the sense, we expect a better visual outcome when it comes to moderate hyperopes, even if there is a variable loss to follow up, which is not seen in this particular chart. So the study could have provided a clarification as to why there were more refractive surprises in case of moderate hyperopes. Coming to the extrapolation, as mentioned in the study, the visual outcome postoperatively can be predicted from the preoperative corrected distance visual acuity. Also, that the study population underwent cataract surgery and phacoaspiration was done in all the cataracts. This helps us drive to the fact that these were early cataracts and were surgically intervened at an early stage. Consider also comorbidities like glaucoma, which are common in this in extremely small eyes, and cataract surgery were also planned for some as an anti-glaucomatous measure. Few intraoperative challenges are also prevalent in such cases, such as poorly dilated pupils, shallow anterior chamber, limited space for surgical manipulation, and also that there are some factors such as pseudo exfoliation and compromised endothelial cell count in relative anterior microphthalmos patients. So, putting all these factors together, we can extrapolate that an early cataract extraction in such eyes would be beneficial. It would ensure a much safer surgical profile and also assure a better visual outcome. As we know that younger eyes happen to heal earlier and better than the older eyes, when we come across such patients, I think we should think from that point of view that an early extraction could benefit them the most. These were the references for the same. Thank you so much.
Thank you, Dr. Chaiti. Very well presented, and I think you've got a good grasp of the presentation overall. You can
Thank you,
stop
sir.
sharing your screen now.
Yes, sir.
The discussion, we open it to the panelists, and we'll talk about the article first, and then generally we'll talk later on about cataract surgery in hyperopes. So, Matthew, sir, are you here?
Yeah.
Yeah,
Dr.
so
Zen, before we start the discussion, I just want to welcome Dr. Mayav Modawala. He's the new secretary BOA and a very dynamic young guy. So welcome, Dr. Mayav.
Thank you, sir. Thank you for having me. And I think it was a wonderful presentation, great points, and I think there's a lot of discussion to come, especially when we talk of non-ophthalmic eyes. We have to be very careful of intraoperative and postoperative complications. So we have to assume that there may be something happening in them, and thinking of the sclerotomies is very, very important. So I think taking that clinical discussion forward, especially with Krishna Prasad sir in mind, would be extremely important, sir.
Thank you for those inputs.
Thank you, sir.
Matthew, sir, yeah,
Yeah.
can I have your comments?
So, actually, the biggest limitation of the study is the fact that this is a retrospective study. And in a manner of speaking, it is difficult to have a prospective study for this kind of large numbers. So that is about acceptable. Regarding the Mari framework, I think Dr. Sengupta would probably be better qualified than me whether the Mari framework is applicable to a retrospective study, uh, especially where there is no comparison arm. Then, in terms of intraoperative challenges, they have mentioned, but they have not mentioned. I find it difficult to accept that 68 non-ophthalmic eyes underwent surgery with no specific, what do you call, uh, precautionary measures, and out of 300, only a very small number had PC rents. So there are gaps in the kind of clinical information that we would have liked to have, and that is another critique for this study. In terms of the numbers are very good. Um And the other thing they could have done probably was they had all the measurements for the IOLs. So if they could have interjected those numbers into the current formulae that are available, like the Barrett or the Kane, whether any of these newer formulae would have given a better outcome in the current with their data set. And last and final, my point is they have taken their primary cutoff as 30 diopters of IOL power. But there are a good percentage of very small eyes or relative anterior microphthalmic eyes where the cornea compensates. And so you have a steep cornea with a very short eyeball, but the overall power is maybe 26, 27, and but the axial length is only 18, 19. So they could have possibly missed out on a reasonable number of patients if they had taken the morphological classification as the primary cutoff and then looked at the IOL power in that uh, morphological setup. Those are my observations. Yeah.
Thank you, sir, so much. We'll get back to you. KP, sir, your thoughts on the study?
I think I agree with Dr. Matthew in most of the points. I think it's a very outlier situation, but I probably expected a much different kind of a study. As he said, this is kind of a semi-whitewash thing. Like it's a very situation, a pretty good outcome, and a lot of things that we expect in small eyes because they are not really very small. Most of them are kind of a so-called simple cases for a veteran cataract surgeons, but it's still an outlier situation. We would be basically in any such research, the takeaway points to the OT would be like, or in the OPD would be basically the IOL power calculation. In the present context, that becomes the biggest elephant in the room that we can't ignore. All these eyes are small, no formula really fits in well, and many of the IOLs will have a very high power. Sometimes they have to be customized. And as the IOL power goes up, the kind of the reliability by the manufacturing companies also slightly comes down. And exactly where the IOL sits, the effective lens position is anyway anybody's good guess. And any slight movement, even zero point 0.1 to 0.5 millimeter movement back or front can completely upset their because they're very thick lenses with a high dioptric power. So any changes in the ELP can really spell a disaster. That's something, and even when you are actually calculating the axial length also, because any small error in the axial length, it's normally we say 2.5 to 3 diopters per millimeter, but here it can be 4 or 5 millimeters in a small eye. So this is one area where every surgeon wants to really know what are the takeaways in the calculation of the refractive outcome and what best can be done. The second thing is intraoperative. As Dr. Matthew said, you do expect a lot of complications, and especially in very small eyes where there are thick sclera, vortex compression, and a lot of precautionary measures. We do a vortex vein decompression. Some people do preparatory sclerotomies, and not having any kind of such kind of a post-operative, untoward outcome is something. It's pretty good, but normally in a real situation, we do expect a little bit of some such effusion problems. But at the same time, what is my observation is it's over 25 to 30,000 surgeries. They have really shortlisted 300. So when you have so many patients getting operated in an institution or a group of institutions, the surgeons vary, their relative competences vary, their kind of experience varies, the machines vary, the situation varies. And there are so many variables that can happen because it is not a single surgeon study and it's not a prospective study. There are no set typical guidelines, intraoperative, preoperative, or postoperative. So with that kind of a situation being applied just to selecting 300 just out of axial lens or IOL power from a very large number of patients, it is difficult to actually draw any kind of a tangible, some kind of a guidelines for a cataract surgeon. That is something. And most of these people are, and I think one I heard that the preoperative best corrected visual acuity were almost equal to the post-operative uncorrected visual acuity, which means that there was not any much of a residual refractive error most often, and probably were assuming they were clear lenses. But there is always an element of a magnification factor. Somebody is wearing +8 preoperatively with no cataract. Obviously, he will be seeing much more magnified view of the chart. And once you make him emmetrope, as in case of LASIK, hyperopic LASIK, patients are not very happy because there's a loss of magnification factor from the hyperopic correction. So that something is another factor that we need to see. But if the patients are already presbyopes and hyperopes, they will be pretty happy with in today's situation, trifocal lenses and presbyopia correcting IOLs. So the subjective aspect of the outcome, we are not just objective, because what refractive error we finally end up with and what the patient does with it is something two different things. So even the subjective evaluation or the satisfaction index about the refractive outcome is something that we also expect in these situations. But otherwise, it's a good thing to start off discussion. I think a lot of things can come out and we can extrapolate this data to the present day current practice so that we can definitely learn from the discussion. Very well presented, Dr. Chaiti.
Thank you, sir. Thank you very much.
Thank you, KP sir. Vavikar sir, your comments on the article.
Yeah, first of all, Dr. Chaiti, very good presentation. You have summed up quite nicely. Now,
Thank you,
most
sir.
of the points have been covered by Dr. Matthew and Dr. Krishna Prasad. So I will have to add only few. Number one is biometry. The last case has been done in December 23, and Barrett has been around for at least 10 years. So why they are not used Barrett? Hill RBF has been there, Kane has been there, and why they are not thought of averaging? Okay, they should have spoken about how meticulous they were regarding taking K readings, biometry, etc. Then just before surgery, mannitol, whether it was given or not is not clear. During surgery, okay, then preoperatively, especially in non-ophthalmic eyes, they should have measured scleral thickness, because when the axial length goes below 20, there are very high chances of UVL effusion, and that is somehow correlated at least vaguely to the scleral thickness. When the scleral thickness is less than 1.7, then intraoperatively, they, whether they have used AC maintainer, whether they were prepared for vitreous tap, and somebody mentioned about sclerotomy. I think Dr. Chaiti only mentioned about sclerotomy. So all these things are not covered. But at the same time, like as Dr. Matthew said, see, it's very difficult to get data of so many short eyes, and therefore we have to go ahead with whatever we have.
Dr. Sengupta, your thoughts on the Murray framework for a retrospective study without a comparison group?
So I'll just share my screen. So I'll talk about a little bit of the statistics first. Hopefully you're now kind of seeing my screen, right? So this is
Yes,
the
sir.
paper. Okay, so 2-3 things. I'll sort of first show you that this appears like a very grave mistake, and then I'll show you that why they are still perhaps plausible, right? Okay, so first thing is, they said most previous studies are talking about biometry and not about many other things, but they are also in fact talking about biometry and refractive surprises. They are also not talking about pretty much anything else. So there are far better studies about short axial length, especially from India. Let me show you some. So this is from the Arvind Eye Care System, which talks about 114 eyes with nanophthalmos, actually 144 eyes actually with nanophthalmos, and their actual mean IOL power is 38 diopters. That is what most of us actually have in mind when we read a topic like this. And let me show you the complication rates. So these are the complication rates without sclerostomy and with sclerostomy. So this is very large complication rates. So then actually their nanophthalmic group pretty much doesn't seem to have anything. So, we know complications do happen. So, what they are what this current paper is describing is actually very improbable. It's like, yeah, very few eyes may be that small, but then, so what we really want from the paper, that paper is, what the topic or the title promises, the paper is not delivering. Whereas some of these other Indian papers are delivering, and all of these are written by Dr. Sharmila from the Arvind group at in the glaucoma clinic. So this is a really good paper if somebody wants to take a look at what really happens and what you can take home to your own practices. Okay, now looking at this, some statistical questions, so if you see, they say logarithm of, the UCDBA was 0.47 and the preoperative corrected distance vision acuity is 0.34, right? So this is 0.34. Let me try and highlight this a bit, right? So this difference is 0.47. That is 1.3 more than, so 1.5 line difference. Of course, this is corrected, this is uncorrected, but still that difference 0.47, whereas 0.34 and 0.28, it's just about half a line. That p-value is 0.02. You're getting right. So it's like when the difference is very large, p is still not significant. And when the difference is very small, p is still significant. And so why is this happening? And is this right? Is this plausible? Is something that, when we are reading it with a very fine comb and trying to take home messages which may be there underlying somewhere, this is important. So, at first glance, it looks like, oh, this is not possible. But then, one is uncorrected, one is best corrected. So they are actually not paired values. They are different, right? And whereas pre and post, they're actually paired samples. So we'll come back a little bit to that later on. So, so at first glance, that looks like there's a very grave error, but later we'll see why it is not an error. Then, like I said, they are also talking about it's, the biometry is imprecise, but they in the abstract at all don't tell us about how they did their biometry. What formula was used, what axial length method was used, what K values were used. It's there in the paper, but then this method section should definitely have something about biometry, especially when they are concluding about all these BCVA, this, that, and error. And then they're saying, there is only one line which actually we were looking for, the last sentence, which says PCR is 3%. So everything else is about biometry, and I mean, it's about refractive correction, right? So then, the whole premise, if you look at the whole introduction, and they say, what they say, high IOL power is more than 30 diopters, but who says so? I don't believe. I said 32 diopters. Zen may say 33 diopters. So there needs to be a reference for this. And what they really say is that the main premise of the study is that, however, previous studies have either not differentiated between above mentioned morphologies or have exclusively focused on characteristics such as IOL calculation. But that is pretty much what they are also doing. So then, that novelty factor isn't really there. Okay, now, like Bhavika sir has already pointed out, actually the Kane formula was there since 2021, and there is no mention about the Barrett's, which we all know really works. And whether it really works in very small eyes, something that we don't know very well. So then having Barrett somewhere here would have actually made quite a bit of difference. Which formula was used, whether they did averaging or not, they have actually not told us. Okay, now let me show you something. Also, when you look at ASOCTs, most studies which talk about opening as angle opening distance or TISA 500 and 750 and all. So most people don't talk about angles. But the Anterion and all these Heidelberg machines do give us the angles. But then most people, most studies talk about AOD. So then that would have perhaps been a better way to represent it. Okay, now look at axial lengths. It says 31.62 plus or minus 1.65. Based on this mean and standard deviation, you can actually calculate 95% confidence interval. And the formula is mean plus or minus 1.96 into standard deviation. You can just ask this to a large language model and it will just tell you. So the confidence interval is 28.39 plus or minus and 34.85. That means there are some eyes which are below 30. Right? They say 30 diopter liya hai hamara, the inclusion, but then it is 28.39 in one extent is that. That means there are some eyes below 30. There is the second group of relative anterior microphthalmos. Again, it's 28.17 and 34. And third, moderate hyperopia. Again, it's 28.3 and 33.16. So then, that less than 30 or 30 or more is what they say. Is that true, or are they actually, what are they doing? Are they lying, or, what is this? So again, this is also plausible. Why? Because this formula that I showed you is actually very relevant only if that distribution is real, near normal or not normal. So here is what you see, so almost all eyes, at least out of 300, this is more than 200 eyes, are actually exactly 30 diopters. Right? And then all these are tails. So these are mostly those nanophthalmic eyes. but almost all the others are like 30 diopters. So the histogram appears consistent with cohort restricted to IOL power of it's not above 30 diopters. Actually, it's almost exactly 30 diopters. So there seems to be some cherry picking here, right? Somebody said that it's not easy to get, but out of 25,000, I'm sure there are more eyes with which they have not perhaps not taken. I'm not so sure, right? And that formula of 95% confidence interval is important when it is normally distributed, right? So more than or equal to 30 is what they say is good. If you say more than 30, it is not the same. Right. So whenever you are also writing your own inclusion, if you have to be actually very careful. Where does a 30 diopter fall? Am I including or am I not including? So in the inclusion, they actually say more than or equal to 30 diopters. And last thing I wanted to basically bring in is repeated measures, something called repeated measures, where there is 191 patients and 300 eyes. That means about 107 or 109 are contributing both eyes, and the rest are contributing only one eye. So this is called mixed effect models. And when that is done, then these p values are actually plausible, that that 0.47 and 0.02. But this statistical analysis section is very, very incomplete for us to actually know what they are doing. So how are these repeated measures? There are two repeated measures here. One is within patient, right? And then that is pre and post, and then some patients have both eyes, right? And then pre and post is also a paired sample. So then there are two levels of repeated measures. How was that done? And that's something that they should perhaps have given a little more in detail, so that we actually believe these p values slightly better. So sort of the take home message is that even if you are looking at these and using saying that, oh, I'm using a large language model, and sometimes these models are good and they may actually point these out to you, but then authors may still be right. So then look at maybe 2-3 models and see what they're saying, and don't always believe large language models.
Thank you, sir, for that critique. Dr. Anuja, over to you. You would like to ask some questions to the panelists. We can have a discussion.
Yeah. Good evening, everyone. Considering the comparatively high unpredictability of the post-hoc refractive outcome, I would like to ask the esteemed panelist what will be your target refraction in such cases, and what are the choice of IOLs?
Okay, we are having some Hindi music. Okay. Yeah, panelists, anyone, KP sir, Matthew sir, Vavikar sir, you can take the question.
Can just mute everybody else apart from our panelist?
Yeah, Matthew, you can go first.
Okay, thank you, sir. So, in my current practice, my target refraction is basically plano. I don't try to be too much myopic in an individual who is prior hyperopic. In terms of choice of IOL, it's actually a little bit limited, because above 30, 32 diopters, you don't get too many of the aspherical models. You don't get too many options in toric unless you're going for custom torics. And so often it will end up as just a spherical IOL that goes into the eye. I've had one situation where two siblings, 4 eyes, with very high hyperopia preoperatively. At that time, this was before custom torics became available. So I did plus 40 IOLs for both of them in both eyes. And then I did a top up with an ICL to correct the residual refractive after that. So I would plan for plano or mild hyperopia, not too much of myopia post-operatively. my current choice of IOL power calculation is definitely the Barrett. And preoperatively, I definitely get the sclerochoroidal thickness measured. And my current standard of practice is I would use Viscoat and not just any other equivalent OVD. No financial interest there. In all patients with relative anterior microphthalmos, it would be just Viscoat. In the axial hyperopes, I would use Viscoat, and preoperatively, I would use Diamox. In nanophthalmic eyes, it would be Viscoat, Diamox, as well as mannitol. And I would be prepared if I see an intraoperative hard eye to stop the case at that stage and take up the case at a later date. I have burnt my fingers quite badly in one situation where I tried to proceed with an intraoperative hard eye and ended up with expulsive. And so close the case, wait for 24, 48 hours, do a B scan and see what is happening, and then take it up slowly at a later date in a safer setting.
Interesting, sir. Thank you. KP, sir, your take on the same, the
Yeah.
biometry as well as the
Yeah,
surgery.
we need to actually divide this into two. Like as Dr. Matthew said, the typical nanophthalmist, where you need to really order the lens, is not available, like plus 40, 50, like that. So there's a lot of unpredictability, and even at the level of the manufacturer, at the level of the biometry, and finally where the IOL sits. So obviously here it's a whether you are making one diopter myope or emmetrope doesn't really matter, because finally it is the patient's luck. And many a times, probably polypseudophakia would be the option. As it now, either a piggyback IOL or presently we have now phakic IOLs. I mean, we can put over the pseudophakic IOLs. So we can put polypseudophakia as to get the bang on, because whatever you put in such eyes will always be a good guess, and it can always either go this way or that way. But like the cases, most of that we found in this study, which are relatively easy, with the present day in IOL formulae, with the like normally we do on both IOL Master 700 and anterior, like we always cross check, we take multiple attempts, we really take our time to pre-op evaluation, do it very deliberately and very slowly to get the IOL power. Most of the times, I again plan emmetropia, not myopic, and most of the time it's quite bang on. And with all these kind of axial lens that normally we saw in this study, the predictability is pretty good. Like the present IOLs do really well, especially Barrett Universal, Barrett Suite really works well. So that is how it is. And the as he said, the viscoelastics make a big difference. Keeping the eye soft makes a difference. You have to really block and give a massage, see that the vitreous is dehydrated with mannitol. And I have in 2, 3 cases, I have even tried in very extremely shallow anterior chambers. I have done a limited 25 gauge vitrectomy. Just enter the pars plana and just remove a little bit of vitreous so that it deepens and you can done it. But probably that may not be required in most cases with the given the kind of viscoelastics and the technology that we have. I think that is what actually, at the same time, the most dreaded thing is the effusion or the choroidal hemorrhages, which has to be looked into. And a short surgical time actually really saves, and a soft and a dehydrated vitreous definitely works well.
Vavikar, sir, your take on biometry and surgery.
Yeah, very good points put by both of them. See, first thing is um, choice of IOL. I think Dr. Matthew has already covered very well, so there is nothing much. As far as biometry is concerned, there was a long time when I used to get hypermetropic surprise, and therefore I was aiming for -1. But last 5 6 years, we are using average of Hoffer Q, Barrett Universal 2, Hill RBF. Now that previously we had 2.0, now we have 3.0, and Kane last few years. And with that, we are very much bang on target. So there is no need of considering -1. Uh, Preoperatively, I'm talking about nanophthalma size. Uh, I would definitely use AC, okay, mannitol and Amox. If the scleral thickness is more than less than 1.7, I will keep VR surgeon standby for sclerotomy or vitreous tap. Luckily, up till now, God's grace, I have not got a case of UV effusion, but you don't know. Anytime you can get, there's always serious risk. Uh, I would use AC maintainer, okay, with low bottle height, because we do not want, we want a continuous pressure from above, but we do not from above, but we do not want it too much. And viscoat is the again OVD of choice. And if you see any signs of UV effusion, the best thing is to close the eye. And um, I think KP said that fast surgery is definitely the way to go. Even if you get a relatively small rexis, that is fine, but rexis going out is not pardonable. And especially, in this case, PCR is also not pardonable. We have to be extremely cautious about doing the surgery, that patient should not get PCR. As such, there is a very high incidence of glaucoma. On top of that, PCR means you are going to be, complicate the situation further. So I think that's it.
So, to the panelists, what about the use of super viscous agents apart from viscoat, like your Helon GV and all those to create space? Are those any of you all are using those, or viscoat is the go-to?
Actually, I have used Helon GV long time back for posterior capsular axis. Okay, in pediatric cataract, but like last almost 15 years, 10 years, I'm not doing pediatric cataracts. And what I found is that viscoat is really effective. So there is no need to go to, agents like Helon 5.
Helon 5.
I think the problem is if you are used to viscode, your movements are calibrated to viscode. If you suddenly use Helon 5 or Helon GV, there's a possibility of misreading the movement. So it's always better use the viscoelastic that you use always.
I had a question. Any role of prophylactic sclerotomies in nanophthalmic eyes?
Yeah, see,
that is the paper that Dr. Sengupta was just showing. The Arvind Eye Hospital study definitely shows that prophylactic sclerotomies in nanophthalmic eyes considerably reduce the risk of intraoperative complications.
So whether a superior one or an inferior one or two, that is another question.
So what they have advised is only inferior one, 2 in number, and a window of 2 by 2.
Yeah.
And preferably with a flap. But
With a
again,
flap.
yeah, but again, we have not done it. Meaning we keep the retina surgeon standby.
Okay.
I do not know whether that is a correct practice, or doing sclerotomy itself when axial length is very low, less, and the scleral thickness is very low. I mean very high. Whether it's a good practice to stand by, I do not know. But we do have it in mind. We did not have to practice.
Okay.
I think the role is it is possible to have an effusion or a problem, and a sclerotomist will save the day. But the relative incidence of such complication is actually so low in the present situation. It may be creating extra morbidity if you are really trying to do it as a routine thing. As he said, if you take all the precaution, do a quick surgery, keep all these things in mind, I think we should be able to get through without such a thing. But at the end of the day, it can always happen.
My take on this, if I may make a point, is that we have to treat these eyes such that always the anterior chamber is pressurized.
Pressurized.
Okay. So when we make the paracentesis, immediately put the viscoat inside, chamber is formed and pressurized. And then as you do all the steps of surgery, the one stage where we tend to create a depressurized anterior chamber is At the end of the nucleus management, mentally we are saying, okay, job done. Then you come out, and that is the time when the anterior chamber collapses. And if there is a propensity for uveal effusion to happen, it will be happening behind the iris at that stage, which we will not notice. So during IA, everything is quiet till the phaco is completed. During IA, you will see the posterior capsule is dome shaped through the rexus. Okay, that is the start of your problems. So a dome shaped posterior capsule coming through the rexus, you know that you are in trouble. Close the case, get out. At that stage, trying to force viscoat, put a lens inside, all those things are very risky. And
So
since posterior effusion is already started, at that point, trying to go into the vitreous chamber and trying to do a limited anterior vitrectomy, etc., is probably going to perpetuate what is a limited effusion just behind the iris. So close, get out, fight another day. Only preventive method is to ensure that you, just like in a PCR, we are taught to use the second hand, fill the anterior chamber with viscoat, and then come out with the bring the phaco out. You have to do that throughout all steps of surgery. AC needs to be formed with OVD.
So what Dr. Vavikar said, keeping an AC maintainer is good so that the chamber does not fluctuate and the AC remains stable.
Absolutely.
I have one more point to sort of add, Dr. Savesaji here. Is that the Arvind study clearly showed that the risk of complications is far higher with SICS than phaco, simply because the chamber is collapsing so much. One
Yes.
second thing is something else from a vitreoretinal surgeon's point of view, something else which simulates this very much is doing phaco in a silicone oil filled eye, where you keep getting this kind of PC bulging is pretty common. As soon as you are debulking the nucleus, you'll start seeing the PC flapping and actually coming towards you. So sort of something which something which need very similar management like or an approach like these small eyes.
But in a silicone oil filled eye, there is a certain amount of fibrosis of the posterior capsule. That posterior capsule is very forgiving. You can go and poke it, nothing will happen. In this eye, you go anywhere near the posterior capsule, it will come.
Last point to the panelists for these short eyes, with nanophthalmic eyes, do you do the iridozonulohyalidotomy to prevent malignant glaucoma? Because that is a practice that is done by some surgeons. Okay.
No.
These eyes are like a time bomb. Don't fiddle with it unnecessarily.
So no experience with malignant glaucoma post surgery for anyone?
There is a possibility of a aqueous misdirection in short eyes. This is possible, but basically, it is not as common as it is thought to be. Basically, the short eyes, there is a higher incidence of aqueous misdirection in these people. But again, I told you, the surgical time matters. And as I said, the post-operatively, no shallowing. That means, so if you are doing a combined surgery, like a phaco trab or something, then there's a very high possibility of a malignant glaucoma if there's a post-operative shallow AC and also intraoperative. So no, kind of a disruption of the anatomy too much during the surgery. I think you are through it.
I think we're also asking some of the best surgeons in the country. So then you're asking the wrong people.
So no, the point is by the experts are very clear, that we need to do it in a very simple way, fast, use your the equipment you are familiar with, maintain all your surgical principles, and treat it like a normal case with, just maintaining everything. So I think that sums it up very well. Vaishal sir?
Yeah, so it was a very nice discussion and really enriches with the experience which they put in, all the three faculties really made everything very clear. So we are already over time and I would like to go on, but we need to sum it up now. And I would ask Dr. Piyush Bansal to put a vote of thanks. Dr. Piyush.
I think it was Piyush who was singing, I think.
Yeah, with a song. Vote of thanks with the song would be great.
So is Dr. Piyush there?
He is still singing.
He's still singing. Dr. Neeraj, if you can do the vote of thanks, please.
Thank you, sir. I think that was a wonderful discussion and a lot of important points put up by all three panelists. So I would like to thank Dr. Matthew Kurian, sir, who's been a mentor. I wanted to introduce him.
Piyush sir is here, Neeraj.
Great, great. So Dr.
Yeah.
Piyush, if possible, can you give a vote of thanks as discussed?
Go ahead, Neeraj. You are phenomenal. You, Zain, and uh, done the program so well. Uh, first of all, congratulations, Chaiti. Thank you for presenting this wonderful, wonderful journal club, and to all our faculties. I would want to especially thank Krishna Prasad sir, KP sir. He is a teacher par excellence. There is nobody like him. Nobody like him. And Bhavikar sir, thank you so much, sir. And Kurian sir, fantastic, sir. All the points that all three of you all brought were absolutely phenomenal. I chose to be silent and listen because these are, opportunities to learn. So, Garat madam, thank you so much. And Zain and Neeraj and Sabyasachi, Tilang sir, thank you so much. And, to everybody, to the entire team for having this lovely webinar. And Vaishal sir, back to you. Uh, Thank you
Thank
so
you so
much,
much,
everyone.
Piyush. It was lovely listening to those Hindi songs in between. So it cut the monotony. And nevertheless, thank you so much for those Hindi songs. And thank you, team, for putting up a very nice journal club meeting today and for inviting such fabulous faculty today. And this topic, which is usually not attended to, got attended, and really very good points came up. So I really thank Chaiti for a beautiful presentation, Dr. Anuja, Dr. Naina for being there, and Dr. Parul Deshpande for making this journal club meeting happen. And thank you so much, Dr. Vavikar, Dr. Kurian, Dr. KP sir. Thank you so much for uh, you know with respecting our invite and coming over to our journal club meeting. And you made it the whole discussion great. Thank you so much.
Thank you very
Thank
much.
you. Thank you. Good night.